To start out, I would have to say that I agree with Dr. Yadav regarding his position on DVT prophylaxis. Let me go over some of the thoughts of DVT prophylaxis that we have in the U.S. What was it? There we go. As we all know, it's a quite controversial subject, and Dr. Yadav kind of went over that clearly, so we don't need to belabor that point. And I went over a few articles. The article I'm going to focus mainly on is, again, DVT prophylaxis by Shushbo, the JBJS article from 2013. And then what the objective was to compare and contrast the use of low molecular weight heparin with the use of aspirin. They did this by estimating the lifetime cost, the quality adjusted life years, and the cost gained. So they did this by, in the study, they either used heparin, low dose heparin, or aspirin 160 milligrams daily for 14 days post total knee. And then they did this they did the life year adjustments from ages 55 to 85 in 5-year increments. And this is the Markov cohort model that they used. Either you were healthy after surgery, had no post-phlebitic syndrome after venous thrombosis, or you had symptoms, or you were a survivor of an intracranial bleed. So when they compared this, then they compared both of these strategies, again, to estimated lifetime costs, cost effectiveness, quality adjusted years, cost gained. And they applied a threshold of $100,000 US. So what they found was that there's really no studies that compare aspirin directly to low molecular heparin, or at least no large studies. But so what they did was to compare heparin with placebo, and it turns out, they compared heparin with placebo, and this was the Royal College of Surgeons. And again, as mentioned before, the rate's relatively low, 0.38%. Aspirin versus placebo, and that was the prevention trial, and that was 0.67. Again, these are low numbers. So if you compare the two, aspirin versus low molecular weight, is about, the aspirin has 1.6 times chance of developing versus low molecular weight. So again, we're looking at a low probability. And when you looked at the major risk of bleeding, low molecular weight was higher than aspirin, but both were higher than placebo. And that's based on the Morrow study at Mayo Clinic. So when they looked at the post-phlebitic problems which are associated with DVTs, the chances of you having it was, and you were symptomatic, is 7% after a year. After 5 years, your chance of getting post-phlebitic syndrome is 14%. 10 years, 20%. So these are the non-fatal problems associated with developing a DVT. So this is really where the costs may come into play. And what they found is that, first of all, the mortality rate with PE was 15%. The medical cost for post-phlebitic syndrome is $2,400 for the first year. Again, this is U.S. dollars. It may not be the same elsewhere. And it's $1,000 per year following that. So those are the numbers that they're using to calculate this. And what they found was that the quality adjusted life years gained from using low molecular weight versus aspirin, it's unclear, but it seems to be favorable in the younger patients, but it's definitely not favorable in the older patients, meaning that if you use aspirin, the cost would be $100,000 for long-term care versus $36,000 if you use low molecular weight. But as you get to 70, it's about equal, and 85, using low molecular weight definitely is the detriment. And so the probability that low molecular weight is equal to aspirin is greatest in the younger age group, whereas it's as you get older, the use of aspirin is definitely to your advantage. And these charts kind of depict what that all shows. Where the top line is for the 55-year-olds, where it's approaching the probability that using heparin is beneficial, whereas the lower line, the 85-year-olds, where it's definitely not beneficial. So the conclusion from that study is that aspirin is more cost-effective than low molecular weight for total knee patients over 80 years of age. And although we're not discussing total hip, for all total hip patients, aspirin is more cost-effective. And aspirin cost-effectiveness is uncertain for patients under 80. But again, we're looking at low numbers, as we were speaking of earlier. Now, again, this is the AAOS recommendation that Dr. Yavad referred to, where aspirin combined with mechanical prophylaxis is safe and effective in prevention of PE and DVTs, and this came out in 2011. So in my practice, I use aspirin 325 daily for 30 days, and I rarely see any bleeding complications. I use the mechanical prophylaxis with the pneumatic compression stockings, and I use early ambulation, where my patients ambulate day 0, usually within 5 to 6 hours post-op, and definitely post-op day 1. Thank you.